my absolute pleasure to introduce Dr. Sheldon Jordan, who was our host and presenter and put together one of the most amazing brain summits. So if you have not heard that, I urge you all to look at that through the A4M offering. Shelly, it's always awesome to see you. Dr. Jordan went to medical school at UCLA and he completed his residency also there in neurology. Currently, he's clinical associate professor of neurology at UCLA and USC. And he's really the medical director of the Regenesis. And Shelly's just amazing. He has over 80 different clinical trials for the most cutting edge brain wellness, health, and optimization that I think you will find anywhere in the country, in the world, even some of them. He's currently also the CEO of Synaptic Research and Synaptic Network and Synaptic Holdings. His research interests really span across many brain optimization and wellness with transcranial magnetic stimulation, treatment of depression. He's really the head of what he's calling the Regenesis Project. And he just literally published a book. I think my copy's coming. I know that it just came out a 3 weeks ago, I think, Shelly. I urge all of you guys to read it because it's going to be an amazing tool really for all of us to continue to build upon brain wellness. So you're in for an absolute treat. I keep teasing him his best gift. Actually, he's one of the most amazing artists that I've seen also. And I encourage you to check his artistry and drawings that he's done also that have a medical twist to them, which are also amazing. So thank you, Shelly, for being with us. The floor is yours.
All right. Thank you, Sahar. So let me make a few general comments. First of all, thank you so much, A4M, again, for putting together a wonderful summit here, and Sahar and Andrew for all the work that he's done, and also the staff, Lindsay and the rest of the A4M staff. They do a great job, and I'm really happy to be a part of this. Some other general comments. So this is a tele-video type of conference. And frankly, I miss you guys. I miss the personal interaction, seeing your faces, shaking your hands, talking to you after I give a lecture. And I lectured a lot around the country. And I got to say that in the COVID period, I really miss that. So, one thing we certainly miss is the feedback. So please remember to fill out your forms and, give us all high ratings, but also if they're bad ratings, I want to know about it so I can do a better job. So having said that, let's move on. So here are my affiliations and conflicts of interest. And here's my disclaimer. And I would point out that Sahar expected me to wear the bow tie. So that's why we have this. She felt that no self-respecting neurologist would get on the stage without a bow tie. So here you go. We're going
wearing a bow tie for me, okay?
Okay, Sahar. So what I want to do today is give you the point of view of a neurologist. And so I do a lot of basic research. I have a very large laboratory, both an animal laboratory and a clinical research organization. We have about 30 trials going on, as Sahar was mentioning. But also, I love seeing patients. And so I'm in the trenches on a daily basis. And what I want to do is impart to you what it's like to be in the trenches, seeing these individuals with COVID acute complications and chronic complications, and also some of these long-term persistent effects. They're now starting to show up. So, we don't know. This is a story that's still being written. So there's some things that I'm saying now that may need to be modified 6 months or even years from now. But let me tell you about what we're seeing, and tell you about what my fears are, and let's take on this challenge together. So first of all, some general characteristics, and other speakers are going to go into this in some detail, but I want to focus on some of the things that are really relevant to the neurological problems with COVID. First of all, the COVID bug attaches to the angiotensin receptor on the mucosa and vessels. It's highly vasculopathic, and I think that that's one thing that's important from a neurological standpoint. Now, by contrast, it doesn't appear to be highly neurotropic. So it does injure blood vessels, and it does injure mucosa, hence some of the complications we're going to talk about. But it's not really all that common that it actually gets into the brain and causes a direct brain infection, at least not in the acute phase. Now, in terms of persistent effects, we're concerned, we're worried, and we're going to talk about that. So we're going to talk about some brain effects, and we're going to talk about peripheral nervous system effects just a little bit. So in terms of the peripheral nervous system, if there are further questions about this and the question and answer period, we can go over that. But basically, you can get an acute neuropathy. You can get, if they're in the intensive care unit, they can get a very sudden neuropathy. If they're the walking wounded, they can get an immune-mediated neuropathy that looks like Guillain-Barré. And interestingly, in some of the vaccines, there have been occasional Guillain-Barré cases that have been reported. So autonomic neuropathy, including POTS, is another thing to keep in mind. Anosmia, very common, and also vertigo and tinnitus are two things, some of which may relate to peripheral nerve involvement. So let's go to the brain effects. So we're going to talk about acute infection. We're going to talk about para-infectious and post-infectious immune-mediated conditions. We're going to talk about persistent effects, for example, the long haulers. And we're also going to talk about delayed effects, including potential Parkinson's disease. So we're going to look at the clinical presentations. We're going to look at diagnostic testing. And then we're going to talk about some potential therapeutic approaches. And we're going to talk about some of the things that I do. So first of all, in terms of COVID acute and neurological effects, let's look at what the presentation is for acute infection. So headache, anosmia, dizziness, occasional meningoencephalitis, and of course, the more acute cases. So COVID headache, that's the most common presentation. So it's along with an anosmia, this is almost ubiquitous. So there's often no prior history of headache, or the headache is described as different in quality and location. And by the way, it's often bilateral. It may be pulsatile or constant in quality. Most often it's associated with photophobia, osmophobia. So in other words, smelling things like perfume or paint thinners or whatnot is really obnoxious to them. They may have a loss of sense of smell. There can also be diarrhea, nausea, and abdominal pain. Interestingly, it's relatively refractory to analgesics, and in particular, if there's a stiff neck or a positive spinal fluid examination, and sometimes a contrast positive MRI, the individual may have meningoencephalitis. This is fairly rare. The MRI and MRV, so that's magnetic resonance venography, may show sinus thrombosis, and that can be somewhat delayed. So someone can come in with headache, and you may think it's a benign phenomenon, and you may be surprised to find out later that there was actually a venous thrombosis. There's been some discussion about whether or not it's proper to use various kinds of agents, including NSAIDs. Initially, there's some caution against this. This is clearly an ongoing conversation. Personally, I use the NSAIDs. They don't work very well, actually, and I often use opioids if the headaches are really severe. So anosmia is probably the most common complaint overall, and we're going to talk a little bit more about that in a bit. So COVID dizziness, well, this is also fairly common. It's often a nonspecific wooziness. There may not be a true spinning around feeling. And when you examine them, you may not see nystagmus with head positioning or spontaneously. And there may or may not be an associated tinnitus. Be careful about POTS. It's a common presentation of these dizzy patients, and you want to make sure that you get blood pressure and heart rate sitting and standing. And if there's a substantial increase in the heart rate with standing, then this is something to think about. And I'm sure many of you are very familiar with what the treatment would be for POTS. So in a summary, this is the main thing that COVID seems to be doing with regards to the body and in particular the brain. So there seems to be an attack of blood vessels. So the receptors, it's the ACE2 receptor, but there are also other receptors that COVID connects to on the endothelium, and it seems that that's where it causes its main problem. In attacking the blood vessels in the brain, there's also one very important secondary effect here, which is those tight junctions that maintain the blood-brain barrier, they're opened up. So now inflammatory factors, potentially other microbes, can actually leak into the brain and cause additional inflammatory processes in the brain. So many of the cases will be infected because of breathing in the COVID, and it clearly attaches to the nasal mucosa, which is why many of these individuals will have anosmia. Occasionally, there can be an acute encephalopathy due to spread into the frontal lobe, and I'll show you a couple of cases that show this. But many of these individuals that have local spread don't end up passing away. So there's actually very little information on how often there's actually virions that can be seen in the frontal lobes. But we have at least some indirect evidence that that occurs on some occasion. We think that besides getting into the brain through the cribriform plate, the nasal mucosa and mouth can also potentially carry viruses to the brain stem. This may be a reason why there's a sleep disturbance because the sleep centers are in the brain stem. It may also be a reason why there's autonomic dysfunction because all those neural networks are in the brain stem. We just don't really know how often there's a direct virion infection. Occasionally, when people have died of COVID or died with COVID, you can find viruses in brainstem. So we know at least to some extent that this does happen. Dr. Song was talking about the vagal connection, and this may be important not just in terms of carrying viruses from the gut to the brain, but also inflammatory factors may also be transmitted to the brainstem through the vagal connection. And here's where the vagus ends up, right at the bottom of the brainstem, and there's definitely an opportunity for inflammatory factors, activated immune cells, and particularly possibly viruses can spread into the brain and do some harm to the sleep centers, the autonomic centers, and eventually into areas that relate to control of movement, such as those issues that may occur with Parkinson's disease. But we're particularly interested in how the blood vessels can play a role in disseminating a virus and the toxic effects indirectly related to the virus. We're obviously interested in arterial spread, but there's also potential for venous spread. So the head is enormously vascular, and there's an enormous venous network, which doesn't necessarily travel always from the head to the heart, but there's an opportunity for retrograde flow because there's no valves. So when someone has a nasal infection or an oral infection with virus, the virus can get entry into the blood vessels in the venous system and can travel retrograde into the brain. So it's not just our arterial flow that can bring things into the brain, it's also venous flow. It may be very interesting that this may be one reason why there's such an incidence of venous thrombosis. So if you do conventional imaging, you often see areas of white matter change. It seems that the blood vessels in white matter are, for some reason, particularly prone to the effect of the virions, and you can get edema that actually shows up nicer in the white matter. If you do a susceptibility weighted imaging, so this is tuned to look for blood products. This is very characteristic of COVID, very characteristic. So what you see are little microhemorrhages, typically at the gray-white interface. So there's damage to the endothelium. The tight junctions are torn apart, and blood vessels can then diapedese from the lumen into the brain tissue. So you get these little microhemorrhages, very characteristic. And it tells you how diffuse this vascular injury can be in these subjects. Look all along the corpus callosum here. There's just multiple microhemorrhages, and all along the gray-white junction. Now, that was a very dramatic case. This is a very typical case. Here you see on what this is a so-called flare image, conventional MRI flare. So this is optimized for looking at changes in white matter, and you see these little punctate and patchy areas, again, typically at the gray-white interface, and this is evidence of microvascular disease. Now, if you were to see this in someone with diabetes or hypertension, someone who's in their 60s, 70s, 80s, you'd say, well, that's pretty normal. But how about this individual here who's a healthy individual in their 20s, who doesn't have diabetes, doesn't have hypertension, and has COVID? So this is a very characteristic change as well, and you'll often see that more often than the other two types of cases that I showed you earlier. So we were just talking about the vasculopathy that occurs acutely in COVID, but we also want to look at the para-infectious and post-infectious conditions. So we talked a little bit about invasion of the vascular system, and it can actually induce stroke because of local injury to blood vessels. There's also demyelination that can occur. So something that looks like an acute MS type of picture where there's demyelination, that can happen. There's this condition called PRESS, which is posterior reversible encephalopathy syndrome. So this is where you get acute edema in the occipital lobes. These patients will have sudden changes in vision and characteristic changes on MRI scan, which I'll show you in a moment. So Dr. Song was spending a lot of time talking about, in children, changes in mood. And this is absolutely typical in adults as well. And Dr. Song was using the pediatric term PANS, so peri-infectious acute neuropsychiatric syndrome. Well, that's not necessarily something that just happens with kids. This is something that is absolutely characteristic of these patients. So high incidence of PTSD, anxiety, depression, sleep disorders, very common. It is probably one of the most disabling aspects, and of course it's treatable, and it doesn't necessarily get better easily. So pay attention to this. These are people that may or may not have had a prior history of a mood disorder, and sometimes it's kind of poo-pooed that, well, you just went through an ICU setting, or you just got scared about having COVID, and you have a reason to be anxious. But actually, there's probably some direct inflammatory effects that relate to these acute mood disorder changes. Some individuals can become, frankly, psychotic, and then be careful that there may be some iatrogenic issues. So, look at the list of medicines, particularly steroids. So steroids are, sometimes used in these individuals, and some people will have a mood disorder, depression, anxiety, psychosis from steroids and other agents. So here are some of the occasional complications of COVID. So here's a patient who's had a venous thrombosis. So this is a sinus thrombosis here. So you can see that there's an opened transverse sinus on one side of the brain in this magnetic resonance venography. However, it's missing on the opposite side because it's filled with clot. And the same individual has a little hemorrhagic infarct in that same area. So how does the virus get there? Is it going through the arterial system to get there, or is it just retrograde flow through the venous system? Either or, maybe both, who knows? But nevertheless, this is not a rare condition. So when people come in with headache, it's not necessarily benign. So occasionally that you can get a demyelinating condition, and this looks like a more kind of diffuse, patchy white matter, mostly white matter change that's acutely, it almost looks like MS. It could be periventricular, can be in the brainstem, as you can see in this case. There have been rare cases of a autoimmune limbic encephalitis. There's only a few cases. We've had cases that look like this. However, really important, don't assume that this is a condition that's caused by the COVID virus, because the COVID virus doesn't give you protection from anything else that might be going on. And here's actually a patient who presented to the hospital with an encephalitis, and it turned out to be herpes. So herpes encephalitis can really be a ringer here, and you want to make sure that you put if you're not really sure what's going on, you want to make sure that they're on antiherpetic medication until you've figured out the serology is involved. So here's a case of that posterior reversible encephalopathic syndrome, where you see changes in edema in the posterior aspects of the brain. Patients present typically with visual disturbance. So we've talked about acute changes and subacute changes. Let's talk about some of the persistent effects. So far, there have been no dramatic effects on the developing fetus, but this is a story that's not finished. You know, you think about other things that are vasculopathic, like smoking. And we know that the effects of smoking during pregnancy really don't show well until a child is in their older years, perhaps not even until they're teenagers. So we don't know what's going to happen to this whole generation of people that have been born in the COVID era. This is something that we're going to be, I'm sure, looking at over many years to come. Anosmia can be very persistent. We'll talk about what you can do in terms of treatment. Now, a lot of the patients that I've seen in terms of persistent effects, they have what I'd call a frontal lobe syndrome. So they seem to have, even though the effects may be fairly widespread, they seem to have changes that can be attributed to frontal lobe dysfunction. So in other words, dysexecutive syndrome. They have trouble making decisions, making choices, planning. They may have an unstable emotional state, so irritable. 1 minute they're screaming, yelling, the next minute they're crying, and it can change from moment to moment. So this kind of lability is something that's very characteristic of these post-COVID subjects. And many of them, because you need the frontal lobes for motivation and attention, many of them will have a reduction in motivation. They may have problems with concentration and attention span. Again, these things are treatable, and we'll talk about that in a little bit. PTSD and mood disorder, I already said that was a very common condition. Again, this is treatable. Some of these individuals will have something that looks like a chronic inflammatory response syndrome. I know that's a term that Dr. Shoemaker used to like, so he'll have an opportunity to weigh in on this as well later. But some of these individuals will come in with fatigue and sensitivity and and just kind of run down and have poor motivation and just sensitive to just about any challenge you can imagine. So there are some individuals that kind of look like that in this setting. So there are delayed effects also. Now, delayed effects are really something that, again, the story hasn't been written. And we're very concerned about this. And we're concerned about it because we have experience from prior epidemics and prior viruses, both conventional and unconventional, over decades. And we're just waiting for the other shoe to drop, but we're actually seeing some glimpses of things that are likely to be a harbinger of things to come. So Parkinson's and Alzheimer's disease, these are two things. Keep your eyes open, folks. Buckle your seatbelts, hold on to your seats, because we're going to be seeing these cases coming in. So let's first look at encephalitis lethargica. So this is a virus complication, or presumed to be a virus complication, from the Spanish flu, 1917 through 1919. Okay, this is the first well-documented huge pandemic. And you get these individuals that not only are they lethargic, but they're really, really slow to move. They look Parkinsonian. And so you're asking this subject to touch her finger to her nose, and you can see this video goes on for minutes before she even gets that finger to the nose. And she's not really asleep. She's just having her eyes closed, but she just cannot get that finger. Look how slow she's moving. All right. So that was the initial experience, but look at COVID. We're seeing things that are actually not that different. So here we have this Parkinsonian syndrome. This is at day 37. So this is a delayed and persistent effect. There's a resting tremor here in the right hand. In this individual with COVID, still in the ICU, you can see a resting tremor in the feet. And you see a little bit of a postural tremor. He's very slow to tap his fingers. So you tell the individual, tap your fingers as fast as you can. And by the way, look at his face. There's no facial movement. He has that hypomimetic face. It looks like it's almost frozen. His eyes don't blink. It's really kind of a typical type of Parkinsonian feature. And look how slow his right hand is. So it's going to be very, very asymmetrical, which is very typical for just even idiopathic Parkinson's disease, not to mention the post-encephalitic forms. Here's another individual, and she was not an ICU player. This is someone who just developed Parkinson's in a delayed fashion. She was not acutely ill. She was not on a respirator. She just developed this syndrome where she's very slow to move. Look at right hand, which is dystonic. So this is sort of an atypical Parkinsonian syndrome. She again has reduced eye blinking and that hypomimetic face. Her right hand is very stiff and dystonic. She has slow movements even in her left hand. And she's slow to move and to walk. So we talked about Parkinson's disease, and there's also Alzheimer's disease. So in Alzheimer's disease, there's a real problem here. The patients with Alzheimer's disease, first of all, have an increased mortality. It's very striking. So if you look at this bar graph here, you look at COVID plus Alzheimer's disease, and look at the mortality rate. And you look at just the mortality rate of Alzheimer's disease or COVID alone without Alzheimer's disease. And if you were to put these graphs together, it still does not account for the high mortality rate. So in other words, this is more than additive. So these patients with Alzheimer's disease, they get really sick. And as most of you will know, there is an inflammatory component to degenerative diseases, including Alzheimer's disease. And the thing that these folks don't need at all is more inflammation that comes with COVID, and they really do very poorly. And by the way, their mental status deteriorates very rapidly. and many of them will end up dying from the COVID experience. So we expect to see a progressive degeneration in a more rapid fashion over the next coming years as a result of COVID exposure for those individuals who have managed to survive. And there are many things that we would look for. And by the way, many of these are things that we can look at and potentially treat. So sleep disruption, vascular injury, there's energetics and redox stress, there's disruption of particulate drainage systems, the lymphatic system. We're going to talk about that in a little bit. There is damage to neurons directly to some extent, directly and indirectly. There's inflammation and microglial activation. So the resident immune cells in the brain are really turned on and produce an excessive inflammatory reaction. There's damage to stem cells, so there's less of a regenerative capacity. There's opening up the blood-brain barrier. There's dysbiosis in the nose and gut. And of course, these individuals are more immobile. They don't get the exercise. They don't have the mobility that maintains their health. So all of these things kind of add together to make sort of a perfect storm for a worsening of a degenerative process. So just to illustrate, for those who are visually oriented, just to illustrate some of my illustrations to look at some of these issues. So the blood-brain barrier has tight junctions between your endothelial cells. These are opened up in the acute inflammatory stage of COVID, and other microbes can get in the brain. So this is not just about toxic influences getting in. You also have the ability for things like porphyromonas coming from the mouth can get into the brain more easily and produce their local toxins like the gingipains. So this may not be just singly the virus effect of the brain and not just the cytokines that are causing problems, but they may be also a permissive effect for other microbes. We also know the relationship between the gut and the brain, and we know that there's a change in the biome in the gut with COVID, and so now you have pathological bacteria that are more pro-inflammatory. That those bacteria are sensed by the dendritic cells in the intestine. That activates the immune system, and now you have a crosstalk through the blood system and also through the vagus nerve. You have a crosstalk between the gut and the brain that can increase the inflammatory process in the brain. There's also this issue about proteinopathy. So as part of the inflammatory response, the brain will make certain proteins to kind of fend off the invasion, the challenge, the inflammatory response. And most of you are familiar with A beta 42, which seems to be stimulated by infectious and inflammatory challenges. The problem is this tends to be a self-propagating effect. So you start to get deposits of amyloid plaque that in and of themselves become more inflammatory. And when these plaques build up, they block the normal disposal system. So there's normally a movement of fluid, of interstitial fluid, from the arterial through the venous side of the brain that flushes out particulates. But this lymphatic system is plugged up, so that there is a backlog, a backup of these inflammatory substances that makes everything even worse. But here's the most important thing. This is probably by far the most important thing. This is also important in Parkinson's and Alzheimer's disease, by the way, is that there's a disruption of the normal neurovascular connection, so that neurovascular coupling is lost. So the neurovascular coupling depends on healthy blood vessels. So when different parts of the brain are more active, there is normally a call for more blood flow and nutrients. So normally the vessels will accommodate by providing more blood flow on demand. But what happens when blood vessels are damaged, they no longer will respond in an appropriate fashion. So they become sort of passive pipes. So the brain is requiring more blood flow and it doesn't get it. So this produces a redox oxidative stress. So there's a bioenergetic challenge here that when blood and nutrients and oxygen is needed, it doesn't get it. So a little bit more about some of the direct virus effects or potential virus effects, because we're worried that in some cases there may be a latency that a virus can get into the system and just kind of hang out, maybe not in very big amounts, but chronically it can kind of erode the brain tissue, produce a chronic inflammatory response, and damage brain cells over the course of years with a certain latency. So there are many conventional agents that we know do this. So measles, rubella, PML, herpes, HIV, influenza, SARS, the earlier ones, and MERS, again, an earlier COVID virus. We know that these things can get into the brain and cause a dormant state, which can be activated over a long time frame. And then there are also unconventional agents that are prion diseases. So this is just looking at individuals with Alzheimer's disease that when they're positive for herpes serologies, and you look at them over the course of years, those that are positive and those are negative for antibodies to herpes, there is over years, there's a markedly increased incidence of Alzheimer's disease developing. So the point is that herpes seems to be something that kind of hangs out and it's in the brain, and you can find them in the amyloid plaques in Alzheimer's disease. They just kind of hang out there and they produce a low-grade inflammatory process that gradually erodes brain tissue and produces, in the long run, an Alzheimer's-like condition. Just a little mention about prion diseases. So Kuru, Jakob Creutzfeldt are the sort of the model for this, but this is just a more vivid display of how these abnormal proteins can be self-propagating. So what happens in Jakob Creutzfeldt and Kuru is that someone eats tissue that has this abnormal protein in it, and there's no virus here. It's just simply a misfolded protein that gets absorbed into the brain, and it induces misfolding of similar proteins in a way that's self-propagating, and it almost acts like a virus, so that it spreads throughout the brain gradually and causes a gradual deterioration of brain function. So in COVID, why is this important? Because in COVID, just the inflammatory response without the viruses even being present in the brain, the fact that it can induce an inflammatory response with there's an induction of some proteins, the protein response itself can produce a progressive deterioration over time. So how do we test? So everybody's going to become a neurologist today. So there's some simple things that you can do that will make a big difference in your practice. I want to impart some very practical things that can make your life easier when you're evaluating these patients. So first of all, very easy to test for anosmia. There's a validated test that uses just 3 stimuli, and you can buy these online. So cinnamon oil, fish oil, and banana oil. These are easy substances to get a hold of. And what you do is you just have them in your testing room, and when the patients come in, just test them. They may or may not be aware of their being an anosmic, or they may say that their smell is fine, but then you test them, give them 4 choices for each one. So for cinnamon oil, you can give them 4 choices: cinnamon, honey, vanilla, chocolate. For fish oil, you can say, is it fish, bread, cheese, or ham? And for banana oil, you can say, is it banana, coconut, walnut, or cherry? So you give them a multiple choice and see if they can choose the correct choice. It's a very easy test. It's been validated. It actually turns out to be very, very useful. If you want to look at the original reference, it's down here for your perusal. So you want to do a cognitive screen. So MoCA, I would highly recommend everybody learn how to do this. It's there's a very minimal fee and unlimited use to use these forms. It comes in 4 different forms, which is really good because there's no practice effect. So you can rotate the forms, and so when you see these patients in follow-up, and there appears to be some improvement in the results, then you know it's not a practice effect because you're rotating the different versions. Depression, I would definitely recommend you do a PHQ-9. Again, it's free of charge. Just use the form. It's validated. It's a very good way of testing for depression. I think a pegboard is a very easy way to screen for Parkinson's and other movement disorders. These can be easily acquired on the internet. And a walking test, just do a timed 25-foot walking test. A normal individual can do this within, 10 to 15 seconds, and with a very small number of steps. So again, it's a very, very easy, validated test that can be done. And then I want to talk a little bit about imaging, because this is something that I don't think people take enough advantage of. Conventional image may not show a lot in these individuals. And by the way, those little punctate and patchy areas of signal change, if it's a middle-aged person, I can tell you the radiologists really undercall them. They think that it may be non-specific, quote unquote. But you have to really put it in the perspective of the patient involved. If they don't have diabetes and they don't have hypertension, they shouldn't be having white spots at age 40 or 50. But there's an easily acquired advanced scan called an ASL, arterial spin labeling. We're going to talk a little bit about that because that turns out to be extremely sensitive in my experience. We can also do a PET FTG or a SPECT scan. These require a radioactive tracer. They're fairly pricey. You may want to think twice about repeating this to follow up an individual because it is radiation exposure, which is why I like advanced MRI for evaluating and monitoring these cases. So we know about looking for atrophy, but these can actually be quantified very nicely with readily available programs. So you can actually come up with a number that you can follow. So here's what happens with arterial spin labeling. So what we're doing with arterial spin labeling is in the MRI machine, we're putting in a spin label. So there's a radio frequency stimulation of blood flowing into the brain at the skull base. And then we're able to track the change in signal into the brain. So it becomes a contrast. It becomes a contrast just because of the way that we changed the signal of the flowing blood. So this is called arterial spin labeling, and we're tagging the inflowing blood at the skull base. So then you can do this sort of subtraction program, and you can come up with a map, which can be then superimposed on an image of the anatomy. And this can be done quantitatively. So you can say 62 mils per minute for 100 grams of tissue. And you can come up with certain patterns that are very characteristic of normal individuals and individuals that might have COVID. So normally, if you map out a signal on arterial spin labeling, you'll see this yellow bright signal, which means more signal, more function in that part of the brain. If someone has a frontal lobe involvement, you'll see a reduction in that yellow bright signal in the front of the brain, and yet there's retained signal in the back of the brain. Look at the difference between these two again. So this is something that we've characteristically seen in patients with COVID. And interestingly, when people are depressed, the signal is a little bit different. You may get some dropout of signal in the frontal lobe, but you actually get increased signal in the frontal lobe that we call the subgenual prefrontal region. It actually is more active. So you think of that as the brain representation of mood, at least the cortical representation of mood, tends to actually be hyperactive in individuals who are depressed. And again, you can get that dropout of signal in the front of the brain. And these things are sensitive to change. So here's an individual who is depressed. He was given transcranial magnetic stimulation, and you can see a return of signal to the frontal lobe. So these things, and there's no radioactive tracer. So you don't have any worry that they're getting repeat scans. So here's another patient with COVID, which is quite interesting, where the patient, and it started with anosmia, and then he developed this frontal lobe disinhibition syndrome, and you can see a dropout of signal just right above the olfactory nerves. So, this is really very suggestive that there's some direct involvement of brain tissue because of contiguous spread. Don't know how often this happens, but here's one case where we saw that, and then we treated him with light therapy and with some other treatments, which we'll discuss in a little bit, and we're able to show that that area of decreased signal in the inferior frontal lobe improved, and his disinhibition syndrome, dysexecutive syndrome, also resolved. So we were worried about Alzheimer's disease. So they have a very different kind of pattern. They have a dropout of signal in the posterior temporal parietal occipital regions, very similar arterial spin labeling to what is seen with FDG PET or SPECT scanning without the radiation. We can look at what's called blood oxygen level dependent imaging. So here the patient is just in the machine doing nothing, and we can look at the connectivity between different nodes of the brain, these so-called networks. So this is a default network, which is you're basically daydreaming, and this is how different parts of the brain connect up to one another. So it's a connectivity map, if you will. And what happens when there's involvement of the frontal lobes is you get a dropout of that frontal component. And this can be looked at statistically. So you can say it's blue here, so it's more than 2.5 standard deviations abnormal compared to thousands of normal individuals that you can compare to. So you can also look at anxiety syndrome. So the amygdala is sort of an area where individuals will have increased activation, and this can be seen on bold imaging and MRI. Get increased connectivity of the amygdala to the contralateral side and to various other parts of the brain. The other thing that we said was very important is the loss of neurovascular coupling. And as people have a loss of mentation, one can actually track this in almost a linear fashion. So normal individual, if you map out the amount of neurovascular coupling, where the yellow is more normal neurovascular coupling, with mild cognitive impairment, you get a dropout. And finally, when someone gets to a demented stage, there's a marked dropout. So neurovascular coupling is something that you can actually measure. So as the virions attack the vascular structures, you can actually show a change in function. We can also look at white matter tracts. We did say that there was some damage to the white matter tracts, and you can pull out each major white matter tract here, looking at the hippocampal output, frontal lobes, occipital lobes, etc. And you can look at the integrity of the white matter. You can look at their amount of myelination, their amount of branching, their amount of axonal connectivity. So all these things can be tracked, and this can be done in a statistical fashion. So here you're actually looking at a percentile map compared to normal controls, thousands of them. You can also look at some of these fiber tracts and mild cognitive impairment and dementia compared to normal, and you can make these nice maps. But they're kind of cute to see, and you can see a dropout of signal. However, it's really, I think, more important is to do this quantitatively and statistically. So let's talk about treatment, and we'll soon be wrapping up our journey through COVID neurology. So anosmia is a major component. It may respond to nasal steroids, unclear, but many people will use some of the inhalable or nasal spray steroids. Olfactory re-education is very interesting. So you can have the individual get different scents and then imagine those scents and kind of relearn how to identify them. And there may be some role for nasal probiotics because there's probably a dysbiosis that's left after COVID infection. And there are nasal probiotics that are on the market. So symptomatic treatment of the neurology of post-COVID, let's run through this fairly quickly. So for concentration fatigue, think about stimulants. Sleep evaluation for sure. If they have sleep apnea, they're going to be much more likely to develop anoxic ischemic brain injury from the hypoxic episodes. So you want to make sure that that's screened for. You can try modafinil for ones that don't have sleep apnea. Depression, I would suggest an SSRI. I don't particularly like using bupropion in these individuals because they're already anxious. TMS might be considered. For anxiety, besides psychotherapy, SSRIs again, benzodiazepines may be problematic because some of these individuals with cognitive impairment, you put them on a benzodiazepine and they really have problems with that. For nightmares associated with the PTSD component, you can think about prazosin. Emotional and behavioral instability, there's a drug on the market that's a combination of dextromethorphan and quinidine. For the dysexecutive syndrome and memory loss, you can use cognitive therapy, but then we can talk about potential disease modifying therapy. So not just for the symptoms, but what do we do for the underlying condition? And I think Dr. Song covers some of these things, but let's look at some of the things that I do. So first of all, sleep optimization, anti-inflammatory measures, including curcumin extracts, DHA, etc., treatment of vasculopathy and bioenergetic stress with nitric oxide promoters, NAC, glutathione, L-carnitine, and perhaps hyperbaric oxygen. Some of my patients had the wherewithal to get home units, and I encourage that. There's some subjective benefit. No one's done the study to see if it really is useful, but people seem to like it. Evaluation of toxins and the exposure that the patients have. Remember, look, if they have fungal exposure and they have mycotoxins, it's going to be even more problematic. So, don't forget all the other good things you're doing with these patients. Treat the vascular factors and hypertension if they have that. The lipomics, I don't use the omega-3 fatty acids by themselves. I use ethanolamine plasmalogen, and we can talk about that in the Q&A if you want to talk about that further. Dental health, you want to make sure that they don't have pathological bacteria in their gums, or that they have root canals that have a periapical abscess that they're not aware of. So the metabolomics, diet, fasting, nutritional supplementation, if they have diabetes, metabolic syndrome, or insulin resistance, those all need to be addressed. Exercise and mobility, you want to promote that. Evaluate for chronic infections. Again, don't give up on all these other things that are probably important, and maybe even more important now that the blood-brain barrier is opened and the inflammatory response is heightened. Nasal, oral, and gastrointestinal biome evaluation support. And then think about the advanced therapy trials, regenerative approaches, including light therapy, focused ultrasound, plasmapheresis, peptides, and exosomes. All these things in my practice, these are all things that I'm doing. These are the 30 or so clinical research projects I'm doing. Everything that I'm doing along these lines have third-party oversight, and are parts of experiments. These, in my mind, are all investigational. So TMS is another nice thing we can do. We can look at the functional targets on advanced MRI, and then we can use that to place our magnets, and we can get some very good effects in terms of frontal lobe and depression and other issues that may result from COVID exposure and depression. So if you don't want to use an antidepressant, we can place these magnets in a very personalized way, and we've published this material. Light therapy, people have interest in it. I'd like to see more experimentation. We're doing some research on this, but we have a very powerful focused ultrasound that penetrates the bone, not just one that goes through the nose. The stem cells are also problematic. Those seem to be killed off by COVID. So to what extent do we need to supplement this with stem cell infusions or exosomes? That's something that other speakers will talk about, but it's also a very important area of my research. So in summary, anosmia is the most common problem and is usually reversible. Headache is common and may persist. Causes are multifactorial and are not always benign. Frontal lobe syndrome with memory loss, inattention, emotional lability, and mood changes is a common persistent problem and can be treated. Each component can be treated. Note the occasional strokes and seizures. Psychiatric symptoms are common, including PTSD and associated issues, including insomnia. This is not just because of their experience in the ICU or the fear of COVID. There's probably some direct effects that need to be addressed. We are all worried about delayed brain degeneration, and we anticipate that the experience may be very similar to prior viral pandemics. And then I would leave you with the statement that I tell all of my patients: everything is treatable. So I'm going to be there to do my best to turn things around, and everything that happens to these patients can be addressed either in terms of symptomatic control, or they can be engaged in one of the clinical trials. So for those who are interested in looking at some ways of helping the brain, not just with COVID, but with all the challenges that happen to the brain in normal and abnormal aging, a lot of the material that I mentioned in this lecture are included in this book. You can get it at my website, but it's also on Amazon Kindle store. And I hope you would enjoy reading that as well. So having said that, it's been wonderful to be here. Exciting to help you out with this challenge. And I'm open for questions.
Thank you, Shelley, as always. I know this is really going to be the post-pandemic of the pandemic is the post-sequelae. And I think neurology, at least the predictions, are going to be hit the most probably with pulmonology, with all this craziness that we're seeing. So thank you for all these helpful hints. And ending on a hopeful note that everything is treatable. Let's do a couple questions and we'll break, and then we'll continue with the, so the first question is, please do discuss the ethanolamine and the plasmalogens.
Okay, so now that the question came up, can I mention yes. Product names? Okay. Yeah. Okay. So you can do pretty well with omega-3 fatty acids that have DHA in them, but you probably have to take up to 4 grams a day. When you take that kind of dosage, people get diarrhea, they get bloating, they get belching. They're not going to be your best friend after that recommendation. So I look for things that are more efficient. So it turns out that this particular ethanolamine plasmalogen precursor, it's made by a company called Prodrome Sciences. So, and they have a particular product. There's actually 2 different products that I recommend in all my post-COVID patients. And by the way, I take them myself because being 120 years old, it's really helpful to have these supplements to maintain my youth. So, yeah,
I just ordered my test. Maybe I'm going to be 120 also.
So Prodrome Neuro is ethanolamine plasmalogen precursor. So it's very easily absorbed. You can take 2 dropperfuls. It's pretty fishy. So you can cover it up with tomato juice or V8 juice, or you can take it as the capsule. But for the capsule, you have to take 6 capsules a day for optimum dosing. So that's a lot of capsules. So the other one that I like is Prodrome GTA. Prodrome GTA. So Prodrome GTA is a curcumin extract, highly concentrated. It's 500 times concentrated. It's optimized for absorption, which, as you know, with curcumin, that's a big deal. Some people like to take just turmeric with black pepper. I guess you could take a mountainful of that and might do the same. But if you want to just take a single capsule a day of the Prodrome GTA, that would be one way to do it. There's another very well researched molecule that's on the market that's called Theracurmin HP. So many of you may be familiar with this. This is 600 milligrams twice a day dosing. It's been looked at with a number of research articles that have been published, peer reviewed. And that's a very good product that would be twice a day dosing of 600 milligrams.
Okay, and let's do this one. This is kind of a fully loaded question, but let's talk everything nose. How do you test for biome in the nose, fix the dysbiosis, and what was it? So yeah, the test biome. And then with the anosmia that you recommended, that protocol, how long till you see effect of that?
Okay, so let's talk about this. So many people will start out with, and again, I can mention names now. Iflonase would be, something you don't even need a prescription nowadays. People will start with that. So there are a couple of nasal probiotics that are on the market, and right now the name escapes me. The one that I've been using But if you can look up in Amazon or one of these other places, there are a couple of powders that you can dip a Q-tip in and just put into the nose. And the name hopefully will come back to me in a minute. I need to take a higher dose of Prodrome Neuro, and I'll get it for you. So then the other thing in terms of for testing, there are a number of companies, and the names of the companies I don't really have because I just asked my staff to send this out. But there are some companies that will do a dysbiosis measure of nasal bacteria. Now, I'm gearing up in concert with some of my colleagues. We're gearing up an advanced DNA sequencing for the nose and mouth, and it's a different preparative pathway than the gut. So I've been working with Sabine Hazan, who some of you may know from the Brain Summit. And I think she's speaking later in the fall Brain Summit, I think. So her company is gearing up to actually get advanced sequencing. What's available now is sort of simple technology that looks at the nose. I'm not sure how good it is, so I have a hard time kind of recommending it. Although I do send out for mouth and nose biomes, and I think the main thing here is to give a probiotic and maybe do the nasal reconditioning, behavioral reconditioning that we're talking about. And then for the mouth, I send them to a dentist. So they need to look for evidence of porphyromonas, to get cone CT scans to see if there's apical abscesses around prior root canals. And if so, it's my feeling that the teeth need to be extracted. But I think if there's anything that you can do to avoid other influences of inflammation that can get into the brain in this heightened inflammatory state, I think we should be looking into it.
So we'll do this, and then Shelley, if you're able to answer the rest in the Q&A, just so we can stay on time. Exosomes, do you do IV exosomes, and also dosing, and where are you sourcing them?
So I'm going to give you a very conventional answer because I want to stay out of FDA jail. Right now, the FDA has published guidelines that suggest that you really shouldn't be doing exosome applications in humans unless it has a specific IND through the FDA, and of course an IRB approval as well, because it needs to be a research project. So I have 4 different FDA approved pathways to use exosomes, and that's how I'm doing the exosomes. Now, in the old days, before the FDA came out with specific guidelines, I have enormous experience using exosomes IV, and then using focused ultrasound, among other energy sources, to localize it to the brain. And we've published on this material in Brain Stimulation and elsewhere. You can look that up. I think simply giving exosomes and stem cells intravenously sounds very interesting. And I think a lot of people are doing this. It's obviously, if you would call it a gray market effort, there are a lot of people doing this. There's a lot of interest in this. I honestly don't know how effective that is. The exosomes that are out there, although by the way, I work with many manufacturers, and I'm agnostic with regards to the exosome manufacturers and stem cell manufacturers. And if you go to my website, you can see that I have a long history working in this material. But what I have to say is that none of these, across the board, none of these vendors that are selling to clinics outside of research, none of them have really fully characterized products. There are some products which I think are better characterized than others, but it's my understanding that the FDA has not accepted the characterization of anybody's exosomes at this point. And I could be wrong, and then maybe things have changed very recently, but this is something that I'm pretty up to date on because I work with multiple vendors. So you really don't know what you're getting with exosomes nowadays. You don't know how much is really there. Is it really well characterized? Is it really safe? We don't know. So I know everybody's chomping at the bit to, me included, to use exosomes and stem cells. But I don't know if this is a timely fashion to do it. Now, I can tell you that there are many people out there that are doing liposuction-derived stem cells. And by the way, I have a very robust pain practice where I use liposuction-derived products. So I'm not preaching against this, but to me, it doesn't make really much sense to do a liposome derivative, simply pulverize it and re-inject it into a venous system. To me, I don't know. That just doesn't make sense. And I think I would feel uncomfortable telling a patient that there's any good evidence that would work to help a post-COVID encephalopathy. I just don't think the evidence is there. I know that there's lots of claims out there, and maybe some of you listening may really dislike what I'm having to say right now, but I'm just telling you, I'm very straightforward with patients, and I think at some point we got to revert to the science, and if you are going to use these products, the Federation of State Medical Boards have given some very clear guidelines, which I suggest you follow, which is basically tell the patients that there's no evidence, that this is a last resort, and maybe if you failed everything else, you may want to consider it, but really there's very little benefit that's been proven. And under those circumstances, if you want to give it and you think that you can evade the FDA scrutiny, I think that there's a window there, but that's not something that I would recommend.
Thank you, Shelley, so much, as always, for your amazing education, presentation. Thank you for all the research that you're doing in neurology. We appreciate it. You're totally turning it from diagnose and adios field into, yes, we can help. Love the bow tie. Keep them. Okay, I'll see you at the next lecture. Thank you again so much.
All right, bye-bye.